Namaskar दोस्तों, welcome to channel Toxicology on board. Today in this video we'll be discussing another DABT topic with respect to risk assessment toxicology. We'll be discussing different point of departures in the dose response curve. In that today our focus will be towards more during understanding what is this frank toxic effect level. So let's directly dive into the topic. So first, let us understand what is this frank effect level. So those toxicologists who are working on risk assessment, they will be already be aware of NOAEL, LOAEL. Certain times when they do the literature search, no, they will end up with a point of departure called frank effect level, FEL. So what is this FEL? We'll see. A frank effect level is a term used in toxicology to define an exposure level that produces unmistakable, severe, typical irreversible adverse effects such as functional impairment or mortality in an exposed population. So, this frank effect level, no, it is a type of toxicity which is dealing with the severe type of irreversible type of toxicity. So what type of irreversible, what type of severe toxicity will come under frank effect level? We'll see some more examples also. FEL represents a point where homeostasis is overwhelmed, causing systemic failure. Okay, so there will be organ failure, irreversible type of damage will be there. Okay, so what are the important aspects with respect to FEL? If you look into the definition of FEL, no, FEL is the lowest dose or exposure concentration that causes a statistically or biological significant increase. You're getting this point in the dose response curve. We know lowest dose. So the lowest dose and that particular dose should be statistically and biologically significant increase in frequency of severity of irreversible adverse effects compared to the control group. Okay, NOEL is there, LOEL is there, lowest dose, then LOEL is called frank effect level. Okay, severity. Unlike a LOAEL, that is lowest observed adverse effect level, which might represent subtle changes. Okay, LOEL can include body weight changes, organ related adverse effects which are reversible upon you can see in the recovery groups. Okay, so LOEL will include those type of changes which are subtle changes, whereas if you look into the FEL, no, it will represent, for example, gross pathology, severe tissue damage, and high mortality. So these type of severity or critical effects will comes under FEL. Dose response. FEL is generally a higher dose than lower, okay, and represent the point where the damage is severe and sometimes irreversible. So always, if you look into this FEL dose, no, it is always higher than LOAEL. Okay, so where does this FEL comes into our dose response curve? We'll learn in detail. In safety assessments, FEL is often avoided in the favor of NOEL. For example, if you're doing a risk assessment for a certain chemical, certain drug, if you have NOAEL, if you have LOAEL, if you are FEL you are having, you should always go for NOAEL because we need to select a dose to which we are extrapolating for the human safety. So we cannot take a toxic dose then extrapolate to human dose. Okay, so that is the reason in the case of risk assessment, FAL is often avoided in favor of NOEL or benchmark dose. Okay, to ensure human health protection. Getting the point? The next, what are the examples we'll see? If you look into the domainic acid, no, we have already discussed about domainic acid under cholinergic. We did one video on cholinergic. In that, there are in the lesson they have given a table is there in which domainic acid is also listed, which is acting through kainate receptors. So domainic acid, what it is causing? It is the best example for frank neurotoxicity, frank effect level. It is causing neurotoxicity characterized by seizure, status epilepticus, and death. Uh, if you are aware of EMA shared manufacturing guideline, no, in that also, if you do when you are calculating permitted daily exposure for severe type of adverse effects, critical toxicity F4 factor, you're taking higher factor 10. So in the bracket in the guideline they will give you for carcinogenicity, for non-genotoxic carcinogenicity, for neurotoxicity, For all this irreversible type of teratogenicity, all this type of irreversible toxicity, in order to address that uncertainty, you have to use a higher factor. So F410 you will be using. So for this reason, here see neurotoxicity considered as irreversible type of toxicity. You have to always when you're doing risk assessment, you have to use higher factor. Coming to developmental toxicity example, we have 10% decrease in maternal body weight during gestation is often considered as frank effector. Okay, and this is another example they have given explosive. So it is causing mortality. So mortality is also considered as irreversible type of adverse effects. Then, if you look into the hierarchy, as I told you, whenever you are doing risk assessment for a certain chemical, if you have NOEL, NOEL, LOEL, FEL, you should always go for NOEL as a point of departure starting dose in order to calculate your health-based exposure limit. If you look into the literature, most of the studies which are done before GLP, that is pre-GLP, in those studies you will get NOEL or certain times NEL also. You can go back and check ICH-Q3C guideline in which certain solvents they have derived a PDE value based on NEL or NOEL. And if you do literature search for a certain chemical on carcinogenicity studies also, you will be finding a point of departure NOEL instead of NOAEL, because here there the main objective of conducting the cancer study is to identify NOEL at which there is no cancer, so no tumorigenic dose. Okay, but nowadays if you look into ICH S9 guideline for pharmaceuticals which are used for anti-cancer treatment, instead of NOEL all these things we have HNSTD, okay, and we have STD. So we will discuss about ICH S9 guideline in some other video. Okay, so you have to always remember what type of study you are doing, what is the objective, and what is the point of final objective. What are you deriving from that particular study? Okay, so these are the different regulatory bodies. If you look into ATSDRO, it will have MRL. European Union will have DNEL, derived no effect level. Health Canada is giving TDI. In case of Health Canada OEHHA, you will also have NSRL and MADL. Those people who are working on risk assessment toxicology, they will be already be aware of this type of health. These are all called health-based exposure limits. So what you're trying to do is you're after doing a animal toxicology study, you'll get a point of departure where you'll select a safe dose and that dose will be extrapolated to the human this thing, okay, by applying certain uncertainty factors. Similarly, US EPA will have RFD for RF and RFC, and the World Health Organization WHO will have acceptable daily intake. So what type of product and what industry they are using, based on the different HBELs will be there. And HBEL is a major syllabus, major important syllabus in the case of risk assessment. If you go back and check your ABT brochure, in that they have given risk assessment carries around, I don't know, 20-30 marks it might be there. So you should be aware of what are the different HBL from various regulatory agencies and what type of product and which industry it is. Okay, so here you can see ADI, the formula is given, and RFD also they have given the formula. And if you look into this uncertainty factors, 10 uncertainty factor is to address the variations in the general population. And if you look into sensitive populations like children, we have additional to address, because children are still growing, their organs are still not yet developed, their metabolism is less when compared to adults. For certain drugs, not for all, we cannot generalize any statement. So we have a child specific assessment factor, CSAF. So many risk assessment books you see or risk assessment documents you see, they will use CSAF, that is child they'll have in order to address that uncertainty, they'll use additional 10 factor. So that also one question you'll get in your exam, okay, with respect to risk assessment topic. And below one is 10 for intraspecies variations, so you should be knowing some other time when we'll discuss on a topic like PD or AD, we'll discuss about each and every factor. So this is the typical dose response curve. Here you can see uncertainty factor, NOEL, NOEL, LOEL, and FEL. FEL is always higher than LOEL. We have seen in the previous video. Okay, and FEL ke liye we have irreversible type, like conversions is there, enzyme change is there. Okay, this type of critical effects will fall under frank effect level. Okay, so we are discussing everything with respect to in this video two textbooks. Handbook of Toxicology will be discussing. We will be discussing Hayes Principles of Toxicology. So this is a typical dose response curve. You can see NOEL is there, and this is a normal biological variation, and here you can see biological insignificant level within this range. Okay, and you have FEL, functional impairment or increased susceptibility to disease. We'll try to read this particular figure 24.19, which is given in the Handbook of Toxicology. See, a dose response curve from a typical toxicology study shows dose-related indices commonly used in risk assessment. What are those indices? NOEL, LOEL, FEL. Okay. A well-designed study should include dose levels which produce frank effect level. That is the reason we say always when you're selecting design of the study, we have control low dose, mid dose, high dose. High dose should cause a little bit of toxicity, and always either low dose or mid dose should end up with a NOAEL. Okay, that is the objective. Whenever a study director, toxicologist will design a study, so a well-designed study should include dose levels which produce frank effect level, LOAEL, either LOEL or NOAEL. Okay, what is the definition? Definitions we have seen in the first slide. FEL is a dose or exposure level that produce unmistakable adverse health effects that cause functional impairment, whether kidney function or liver function, or increased susceptibility to disease. Means immune system will be compromised or disease. And you know the definition of what is LOEL. So LOEL is the lowest dose or exposure level that produces an adverse health effect. If you look into LOEL, no, LOEL is the lowest dose or exposure level that produce an observable effect, but not a degree to which would be expected to have a significant impact on the health of the animal. So many times, as I told you, no, pre-GLP may you will be getting most of the literature NOEL, LOEL. So most of the new studies you will be getting NOAEL, LOAEL. The risk assessment toxicology will sometimes will he will get confused. LOEL is sometimes confused with LOEL, but they are two different things. Okay. For example, in simplest terms, if I say body weight change is there. Body weight change if in case of weight lowering drugs or in case of anti-cancer drug, it can be considered as a severe effect. But if you are taking that with some other from other antipyretic drug or angina drug, where weight lower is not considered as severe adverse effects when compared to adverse effects on the liver or kidney, then that can, and that body weight can be normalized if the treatment is stopped during the recovery period. If the animals again gain back the normal body weight, then that should not be considered as severe adverse effects or critical effects, adverse effects. It will be a little bit confusing, but this is the way the risk assessment is like this only. So LOEL is not equal to LOAEL. A NOEL is the highest dose or exposure level at which no adverse health effects are observed, which are capable of functional impairment, increased susceptibility to a disease. The NOEL can be equivalent to LOEL. So you make a note or you go back to textbook and try to understand. Okay, this is very important in the case of risk assessment toxicologist. A NOEL is the highest dose or exposure level at which no effect are observed outside the range of normal biological variation for the species and strain under the study. So that's why when you are deriving NOEL, you have to also check historical control data. Okay, is the statistical significant, biological significant. Those things also you have to be looking into that. So there is a very important change between a certain substance showing statistical significant, but it is not having biological significant. Then that type of adverse effect should not be considered for your risk assessment for your final NOEL selection. So that's a very big challenge to the study director who is conducting the study. We'll discuss about in another some other video what are the how the biological significant and statistical significant, the difference, and with some examples I'll try to discuss. The effect, if any, observed at the NOEL should not be statistical significant when compared with the control group. Hope you're trying to get today you try to get introduced to the concept. For those people who it is new, then in some other video with some more clear examples we'll discuss. So now we'll discuss figure 24.2. This is a typical dose response curve. You can see these are the uncertainty factors and modifying factors to the NOEL. When we apply, we will be ending up with RFT and RFC. So we'll see what is this graph. A dose response curve from a typical toxicology study showing the relationship of RFD and RFC. NOAEL. The RFD RFC are determined from the data developed from a subchronic or chronic animal study. Means like a 3-month study or 6-month study or 9-month study, you will get a point of departure NOAEL. To that you will apply uncertainty factors. Then you will end up with RFD or RFC. Go back and check US EPA website is there. In that you will be getting for a class of chemicals, for a list of chemicals they have already uploaded. They have done the risk assessment, and they have monographs where they have RFD inhalation RFC will be there. Okay, so from here the animal study and represents an estimate of the level or exposure to which human population, okay, including sensitive population, either child or those people, old people, or somebody deceased person also can be exposed during a lifetime without deleterious effect. If you look into a PDE definition, if you look into ADE definition, so it's similar to that only. We have to we have to derive a dose to which there will be no adverse effects to the subjected human population over a period of time, okay, lifetime. RFD and RFC are used by the EPA for non-carcinogen effects having a threshold. Okay, there should be a threshold. A point of dose should be there on the dose response curve, below which there will be no adverse effects. RFD and RFC are derived by dividing NOEL by the product of several uncertainty factors and modifying factors. In certain places, these are uncertainty factors will be up to F1 to F5. Certain times F6 will be there, F7 will be also there. If you look into extractable leachables new guideline ICSQ3, the uncertainty factors are up to 7. Okay, then depending on the degree of uncertainty and associated with the data, RFD and RFC can span several orders of magnitude, 10-fold, 50-fold, 100-fold, like that, from the NOEL. The reference value RFD and RFC are similar in concept of, as I told you, similar like HBLs for FDA acceptable daily intake, and OSHA will have a list of chemicals, that is permissible exposure limits. Okay. Okay, so as I told you, we'll discuss another textbook, that is Principles of Toxicology, Hayes Principles of Toxicology, Chapter 12. Under that, they have given this particular regulatory process, Chapter 2. So we have table 2.12. They have given different types of severity. They have given order of severity. They have given relationship between effect categories and severity. So what type of effect and what type of category should be there? So our video is with respect to frank effect level. So frank effect level will include pathological changes, definite organ dysfunction, as I told, liver function or kidney function, right, which are unlikely to be fully reversible, means irreversible type of effects. Pronounced pathological changes, histopathologically the tissue has been completely damaged with severe organ dysfunction and long-term sequelae. Okay, over a like 1 year, 2 year, that chronic exposure. Developmental dysfunction, including biochemical changes affecting signal transduction that results in developmental defects or dysfunctions. Means maternal teratogenicity, all will also come under FEL type of effects. And life shortening or death, mortality, morbidity, all this will also come under FEL type of severe adverse effects. So based on the severity, they have given what type of severity should be considered, what type of point of departure. So pause here, you try to read. Okay, for example, enzyme induction can be considered as a NOEL. No observed effects is a NOAEL. Hyperplasia, hypertrophy, so like that. So this table is very important with respect to risk assessment toxicologists who are performing the risk assessment. Then we will try to understand in the same 1 or 2 paragraphs are there in the same Hayes principle. So uh, let us understand in detail. So again, we need not read it back. Okay, let us fully understand the concept. So incorporating information on severity of the effect. A critical difference in evaluating risk for cancer versus risk for non-cancers. So you have to always, when you are assigning the severity of a toxicity to certain chemical, carcinogenic chemicals, you need to give a higher factor when compared to non-carcinogenic chemicals. Okay, so non-cancer effects is that, whereas from the regulatory perspective, almost all types of cancer are considered equally severe, which is completely wrong. There are certain cancers which are benign, certain cancers which are malignant. Okay, so localized tumors will be there. Those people who have seen ICH Q3C guideline, there is pharmacopoeia is there. In that they have for the all the class 1, 2, 3, 4, whatever the solvents are there, no, they have derived the permitted daily exposure. In that they have very in the monograph only, second or third page they have given. In the cancer also, for benign tumors, F4 they are considering 5, and for malignant type of cancer they are considering F4 10. If you look into EMA shared manufacturing guideline, no, F4 by default, if it is carcinogenic certain chemical, they will use higher factor by 10. But that F4 10 for cancer can also be split into benign kele you can go for 5, malignant you can go for 10. This is the concept you have to remember. That is only they are discussing here. Okay. So regulatory, what it will do, regulatory perspective, all types of cancers are considered equally severe. That's what the regulatory thing. But as a toxicologist, we don't think. Regulations based on non-cancer effects can account for variations in severity. In general, regulatory agencies do not distinguish among carcinogens on the basis of malignancy of a tumor type. As I told you, benign or malignant, they are not differentiating. Despite advances in earlier diagnosis and treatment, the fatality rate means the death rate for cancer overall is still relatively high. That is true. Because we have different types of cancer. Most of the cancer they end up if it is in like a fourth stage or third stage, you will end up with a mortality. You can just prolong the individual life up to 1 to 2 years, and even when treatable, the treatment methods are not without adverse effects. The treatment itself is also having adverse effects. The anti-cancer drugs which you are using for the treatment of cancer by themselves will also have, they themselves are also creating secondary type of tumors. Okay. For example, the relative 5-year survival rate for all cancers from 2010 to 2016 is 68% for the white people. Again, there is a ethnic variation. 63% for the black people, meaning that 32% of the white people and 37% of the black people uh, uh, did not survive 5 years of past diagnosis. Okay, now you are able to understand why. So non-melanoma cancer, skin cancers which are related to UV light and arsenic metal, the cancers which are caused by these type of agents or chemicals, no, their fatality is less than 10%. So again, you can clearly understand based on different types of cancer how you treat different type of F4 assignment factor we need to be given. See, what we are trying to discuss is what type of severity of the adverse effect, what type of assessment factor we have to give. That is only we are discussing. Okay. How to categorize a chemical as a severe adverse effects or non-severe adverse effects. That is the agenda what we are discussing here. In contrast, target organ effects range greatly in severity. Target organ means either kidney, liver, heart. For example, using the same target organ and susceptible population, namely airways for the individuals with asthma, that is lung, respiratory system, responses may range from imperceptible mild bronchoconstriction induced by low levels of sulfur dioxide to a fatal asthmatic response, as may be due to acid sulfate population in long London smog episodes. So pause here. We have a video on London smog also. So one question with respect to ABT you will get about London smog, in which sulfur dioxide is the main agent which is responsible for causing this toxicity. So basically here what he is saying is that there are certain individuals who are sensitive. So those who are asthmatic individuals, no, for them this type of same bronchoconstriction is a severe type of adverse effect. But for certain group of individuals, bronchoconstriction can be considered as non-severe adverse effects. Okay. So here this table 2.12, it will keep on coming in next 1 or 2 slides. Range from enzyme induction to severe organ function, corresponding effects categories, that is NOAEL, LOEL. So which type of adverse effects should be given, which point of departure that you should be knowing. Okay. Using these categories, California EPA, Office of Environmental Health Hazard Assessment, okay, recommends using LOEL and NOEL uncertainty factor 6. So you now you understand EMA will go ask you to consider uncertainty factor for a NOEL or LOEL 10. But what is this OEHH saying? Go for lower factor, go for 6. If you look into ECA reach registration will be there, no? When they are deriving DNEL, they are also using lower factor, like overall assessment factor, they will be using 6. Okay. Severity level grade 5 or less for deriving acute um, effect level for inhalation exposure. So hope you are understanding, it's a subjective. From one toxicology to different toxicology, the same adverse effect can be categorized differently. It's a subjective, individual to individual. The assigning of the factor will change. That's why you need a professional judgment when you're identifying a certain when you're assigning a certain factor to an adverse effect. Consideration of severity then becomes important for regulatory decision making in several ways. This is very, very important. That's why whatever the even if you say nitrosamine risk assessment is there, they are giving you acceptable intake. After 2 to 3 years, again there will be revision. Okay. Similarly, ICH Q3C guidelines is there. Again, there will be a revision in whatever the HBL value they are giving. No, over a period of time, when you get more literature, if you have a better NOEL from the existing NOEL, again that particular HBL value change. Okay. For RFT development is an effect such as 2% decrease in body weight, a LOL or lower. So that is a question to us whether that's I told you no whether you will consider body weight as a severe adverse effects or not. But again, I'm saying it depends on what is the nature of the chemical. Okay, for example, you are working on a semaglutide, which is weight lowering drug. Then the decrease in body weight will not be considered as adverse effect. So case by case it is. Does an effect of sufficient severity warrant the protection of 95% of the population or 99% of the population? So it's a question. Go back and think about it. Several agencies and organizations have developed approaches to incorporate information on severity of the effect into risk assessment and risk management process for the environmental chemicals. So now we have new a lot of regulatory agencies, particularly European regulatory agencies, are asking for PEC, PNEC, okay, for the environmental risk assessment. There also we are based on NOEC from the algae Daphnia studies. We are deriving this PEC, PNEC. So that is also very, very important. Then only we will be able to, once you assess the risk, then risk management, risk communication, these all comes in the risk assessment bigger diagram. Okay. So more we have to discuss. Information on severity has been incorporated into reportable quantity. So RQ is the one which is coming under CERCLA. CERCLA is there in your brochure. Go back and check ABT syllabus mein you have CERCLA, Superfund CERCLA, okay, RCRA, Resource Conservation Recovery Act, these are all there. So whenever there is an industry who has who has produce lot of industrial waste, so that waste if they dump in a certain area, spillage will be there. So that particular area landfill will get polluted, or if they drain their industrial waste into a river body, then that particular area will get contaminated. So there are organization called CERCLA or Superfund. These are the ones who will take care of those things. So that comes under product stewardship also. So read about CERCLA. One video will make on CERCLA's Superfund, Resource Conservation Recovery Act. These are part of ABT syllabus. Okay. So they have this reportable quantity definition. What is that we will see. Under the statute, means whatever the legal is there, release of chemicals in amounts greater than some predetermined level. So there is an industrial waste, but you have there is certain limits. You can release in this much amount only. If you are releasing that industrial waste in the nearby water bodies or near in the land, defined as RQ, require that you have to notify the US EPA to be notified that this amount of industrial waste I am going to release. Okay. The amount of release that triggers notification is based on the assessment of the potency of the chemical. This is again very, very important. Persistent and bio PBV, okay, and whether that particular chemical will retain in the nature for a longer period of time, that is also, and potency of the chemical. If a chemical is highly potent, so you cannot release in large quantities. Okay, that's why potency of chemical is also important, and the severity of the effect of the dose level where the potency was quantified. Ranking of severity, this is again, we have come back to table 2.12, where it can be seen that effects range from slight biochemical changes through gross toxicity, including lethality, that is mortality. Unlike RFD process, the scoring is not restricted to data sets. Okay, what type of data, whether GLP and non-GLP, is there any inadequacy in the data? Okay, pre-GLP, containing information on mildly adverse effects from the subchronic or chronic studies. RQ process can result in development of scoring indicators from lower quality datasets involving shorter time periods of exposure and more severity. So there is a difference. When you are taking RFD, the point of person should be taken from 90-day or 1 year or 2 year animal study, right? But in the case of RQ process, you're even for a low short-term study, from that point of departure also you can calculate this RQ. Okay, RQ process demonstrate the use of severity information, both risk assessment and risk management. Risk assessment is developing RQ indicators, and risk management is defining release levels requiring notification is associated with the defined RQ values. Okay, so stop here. You have not only RQ in the ABT brochure, you have something called hazard index. HQ is there actually. Hazard coefficient is there in the syllabus. So go back in the risk assessment only will be getting the risk management and risk communication. Okay, efforts involving the use of categorical exposure response modeling, additional approaches. So I think this particular diagram you yourself read it, because in the dose response curve they have given, there are if you look into the circles, they are NOELs, and these triangles they are adverse effects, and this dark color squares are they are the lethal. So whatever this graph, this line is the below this particular line, we are expecting that we will having a safe dose called NOAEL will be there. Okay, this type of approach could lead to development of concentration time more normograms for the definition of NOAEL. Okay. Uh, so in addition, we also have in the Hayes principles of toxicology only, you have different HBS. I told RFD, US EPA is having RFD and RFC. They've given the definition. You read it. What is the point of departure and what are the uncertainty factors they have considered? For ATSDR, Agency for Toxic Registration Substances, they have minimum risk value. So here you read the MRL definition is given, and ADI, acceptable daily intake for the food additives. Okay, and you have WHO is also giving you ADI with respect to food additives and pesticide residues on the food, on the food products like plant products. I'm saying tolerable daily intake, which is used for chemical, established for chemical contamination. This is also given by WHO. Okay, so read in detail. Hope from this video you will be able to understand about the important point of the batches with respect to risk assessment. Okay, most what we are trying to understand is severity. A certain chemical is showing certain adverse effect. What adverse effects need to be considered as severe, and what should be considered as non-severe, what irreversible. Based on that, we will be, as a professional judgment of a toxicologist, you will assign certain number to that to address that uncertainty. Okay, thank you so much. Be curious. For any questions, you can always write a mail to arya.priyanka18@gmail.com. All the best for your exam.